Okay, sounds good.
So hello everyone, thank you for joining us. And today we're gonna have a nice, excellent meeting, hopefully. So Ryan is gonna lead or moderate this meeting. So go ahead, Dr. Ryan. Thank you.
Hello, everyone. So this week is the yellow team. We're going to start off with a presentation by Dr. Shaza Hassan. She's going to present on hypertension. Please go ahead, Dr. Shaza, whenever you're ready.
Hi, everyone. Let me share my screen. Hi, everyone. How are you?
Thanks.
Did you see my screen?
Yes.
Yes, we can see your screen. Yes.
Okay. So I am presenting today hypertension in elderly population. Objective for this presentation is to know and understand how to diagnose and treat hypertension in elderly, when to recommend lifestyle modification, how to choose antihypertensive medication from different classes, and principles of adjustment of therapy and follow-up. This topic will cover epidemiology and physiology, etiology, clinical evaluation, treatment, lifestyle modification, pharmacological treatment, hypertensive emergency and urgency, and follow-up. Definition of hypertension. Hypertension is high blood pressure above normal level. Above normal level in systemic arteries. It's considered above 140/90 in elderly population. Blood pressure commonly expressed as the ratio of the systolic blood pressure, which is a pressure that the blood exerts on the arterial wall when the heart contracts. And the systolic blood pressure is the pressure when the heart relaxes. Hypertension is a major health problem in elder population. Epidemiology. Hypertension increases with age, affecting approximately 66% of elderly population aged more than 65 years old. Highest among Black and women. Prevalence increasing from 27% in the age greater than 60 to 74% in those older than 80. Elderly population are more prone to having isolated systolic hypertension. More than 65% of hypertensive patients age more than 60, and more than 90% those aged more than 70 have isolated systolic hypertension. Isolated systolic hypertension associated with 2 to 4-fold increase in risk of stroke, myocardial infarction, and cardiovascular mortality. Hypertension in elderly also associated with increased risk of coronary artery disease, atrial fibrillation, stroke, vascular dementia, Alzheimer's disease, and chronic kidney disease and retinal disease. Classification and definition of hypertension. American College of Cardiology and American Heart Association classify blood pressure as normal blood pressure less than 120/80, elevated blood pressure from 120 to 129/80. Stage 1 hypertension defined categorized as 130 to 139 to over 80 to 89. Stage 2 hypertension is 140 or greater, over 90 or greater. Hypertensive crisis is blood pressure more than 180/120. There is another classification from JNC, Joint National Committee. They categorize normal blood pressure less than 120/80, pre-hypertension 120 to 139/80-89, stage 1 hypertension 140 to 159/90-99. Stage 2 hypertension, blood pressure 160 or more over 100. Physiological change with age. As there is change in mechanical dynamic, there is a mechanical dynamic change occur with age, and arterial stiffness also increase with age. There is decline in baroreflex sensitivity and increased sympathetic nervous system activity, and aging kidney, which is there is alternation in kidney function and new hormonal system that involve sodium balance. So at the end, the sodium will retain, and with retain water with it, which contribute to increased blood pressure, and all that due to aging kidney. Etiology of hypertension. Hypertension, most commonly primary essential hypertension, account for 90 to 95% of patients. And this is due to heterogeneous or multifactorial due to gene or environmental etiology. Generally, primary or essential hypertension associated with a strong family history of hypertension, and secondary hypertension, which should be caused by hyperaldosteronism, Cushing syndrome, coarctation of the aorta, renovascular disease, endocrine disorder like thyroid disorder, hypohyperthyroidism, and parathyroid abnormality. Obstructive sleep apnea, drugs such as non-steroidal anti-inflammatory drugs, steroid, alcohol, hormone replacement therapy, immunosuppressive drugs, amphetamines, and all this. Chronic kidney disease and pheochromocytoma. To diagnose hypertension, we need to have 3 or more readings of elevated blood pressure in 2 separate occasions. Or we can take average of several readings taken at each of the 3 visits. 2017 American College of Cardiology considered reading of more of 130/80 or more as hypertension, while European Society of Hypertension guidelines have maintained blood pressure more than or equal 140/90 to consider hypertension. Ambulatory blood pressure monitoring for extreme elevated blood pressure, extreme blood pressure variability, or white coat hypertension, or latent hypertension, or masked hypertension should be performed. which is more in elderly. White coat and mask hypertension and latent hypertension are common among this population. Also, to diagnose hypertension, to be sure of that, determine systolic blood pressure by palpation to avoid auscultatory gaps. Clinical evaluation. We have to evaluate the patient to exclude, rule out secondary hypertension, identify end organ damage as early as possible, any indication to start antihypertensive medication, mind cardiovascular risk factor and comorbidities. So from the history, you have to inquire about smoking history, dietary history, like fat intake, salt intake, alcohol consumption, and physical activity. A goal of therapy for hypertension to maximize function by prevention of fall and injury, prevention of hypotension, reduce cardiovascular events like heart failure, exacerbation, myocardial demand ischemia, and strokes, and to maximize the quality of life for hypertensive patients. So when you control the blood pressure, all this contribute in his general health. Benefit of treatment. Treatment reduce overall mortality and morbidity and cardiovascular events and stroke. Treatment had a greater effect in men older than 70, the patient older than 70s, and also patients with greater pulse pressure. Those type of population gain more benefit from the treatment than others. Treatment targets. Focus in systolic blood pressure. We mentioned before, isolated systolic blood pressure is more common in elderly population. Generally, we want systolic blood pressure to be 135 to 140 and diastolic to be less than 90. If the systolic blood pressure is very high, an intermediate target to be 160. This is better for initial fall in the absence of target and organ damage. The goal for diabetic patients, systolic blood pressure should be less than 130. Treatment target, continue. So 2017 American College of Cardiology, American Heart Association guideline recommended blood pressure be controlled to be less than 130/80. This is target for patients more than 65 years old. 2018 European Society of Cardiology, European Society of Hypertension, I recommend blood pressure to be less than 140/90 for patients more than 65 years old. 2017 American College of Physicians and American Associate of Family Physicians guideline target the blood pressure less than 150/90. 2017 Canadian guideline targets systolic blood pressure to be less than 120 for patients more than 75 years old. Okay, so American College of Cardiology, American Heart Association, and American College of Physicians, American Associate of Family Physician, and European Society of Cardiology, European Society of Hypertension guideline is shown in this slide. So American Cardiac College and American Heart Association in 2017 defined older patient, the patient more than 65 years old, while American College of Physicians and American Association of Family Physicians 2017, they define older patient more than 60. European Society of Cardiology, European Society of Hypertension 2018, they define elderly 65 to 79 and very old more than 80. So the blood pressure threshold for initiation pharmacotherapy, American College of Cardiology, American Heart Association, they consider starting pharmacotherapy when the blood pressure more than 130/80, while American College of Physicians and American Association of Physicians recommend systolic blood pressure will be more than 150 to start medication. The European Society of Cardiology, European Society of Hypertension for elder patients, those at the age of 65 to 79, start pharmacotherapy when blood pressure more than 140/90. And for very old patients, 80 years, they will start the treatment blood pressure more than 160/90. Blood pressure target by American College of Cardiology, American Heart Association should be 130 over less than 130/80. American College of Physicians, American Association of Family Physicians, target blood pressure should be less than 150, and European Society of Cardiology, European Society of Hypertension, the target blood pressure should be 130 to 139. So generally, we will start with lifestyle modification for mild hypertension, and also for even the patients who require treatment, medical treatment or drug treatment. They also should continue to continue lifestyle modification beside drug therapy. So lifestyle modification includes weight reduction, activity, is a diet approach to stop hypertension. Include whole grain, low-fat diet, fish, poultry, nuts, high fruit, and vegetables. A low-salt diet. American Cardiac College and American Heart Association recently recommend 1,000 milligrams per day as a salt in diet should be for the elderly population. Avoid caffeine-contained drinks. Maintain adequate intake of potassium, magnesium, and calcium. Pharmacological strategy. The main pharmacological agents used for treat hypertension is diuretics, mainly thiazide diuretics. Mechanism of action of diuretics: inhibiting reabsorption of sodium and chloride from distal tubule and kidney. So they decrease blood pressure by reducing sodium and chloride, and decrease stroke and cardiovascular mortality. Angiotensin converting enzyme inhibitor, mechanism of action: it blocks conversion of angiotensin 1 to angiotensin 2. So it decreases systemic vascular resistance and decrease aldosterone release. So therefore decrease sodium and water retention and decrease blood pressure. And it has a role in decrease mortality in patients with MI, a left ventricular dysfunction. And AC inhibitor also a drug of choice for patients with diabetes because it decreases progression of diabetic nephropathy. ARBs, angiotensin receptor blockers, direct block angiotensin 2 receptors. So it causes vasodilatation, decrease systemic vascular resistance, and decrease secretion of vasopressin and aldosterone, and therefore decrease blood pressure. It also has benefit reduce stroke, and in patients, it is a substitute for patients cannot tolerate AC inhibitor. Calcium channel blocker or antagonist mechanism of action, it disrupts the movement of calcium through the calcium channel in cardiac muscle and peripheral arteries. So it causes vasodilatation, decrease systemic vascular resistance, decrease blood pressure, decrease cardiovascular complication in elderly patients with isolated systolic hypertension. Beta blocker, it reduces heart rate, reduces cardiac contractility, cardiac output, and inhibits renin release, and increase nitric oxide, decrease vasomotor tone, therefore decrease blood pressure. Other agents, such as direct renin inhibitor, aldosterone receptor antagonist, such as spironolactone, and centrally acting agents, direct vasodilators, alpha adrenergic blocker agents. Thiazide diuretic and angiotensin converting enzyme inhibitor and angiotensin 2 receptor blocker and calcium channel blocker have all shown to have a benefit in cardiovascular disease outcome in elderly populations. Thiazide diuretic or AC inhibitor considered first line or in combination. Okay, so when we start drug therapy should be started when lifestyle modification failed for 6 months. For 6 months and failed to control blood pressure. We start drug therapy for stage 1 hypertension. Target blood pressure should be less than 140/90. First line drug therapy should be diuretics or angiotensin converting enzyme inhibitor. ARBs also can be used as first line sometimes, and calcium channel blocker. All these medications should be started at lower dose and titrated as tolerated. They are effective in lowering blood pressure and reducing cardiovascular outcome in elderly patients. So if the first line agents fail to lower the blood pressure at full dose, we recommend to add second medication. And if the second medication also, after full dose, also didn't control the blood pressure, add third medication as tolerated. When blood pressure more than 20/10 above the goal, consideration should be toward in initiating 2 antihypertensive medication or combination of drug therapy is mandatory. The first line treatment, usually diuretics, diuretics are recommended as first-line therapy for treatment of hypertension in elderly. They are generally well tolerated, less expensive, significant reduction in stroke, coronary artery disease, chronic heart failure, and mortality. Also, diuretic is the best choice for treatment of isolated systolic hypertension in elderly. We have take care about the side effect of diuretics, which is electrolyte derangement, such as hypokalemia, and potassium supplement is indicated to prevent hypokalemia-associated arrhythmia. Also, caution should be taken if the patient's volume depleted, and the dose should be adjusted accordingly. ACE inhibitors are considered alternative first-line antihypertensive medication in elderly population if diuretic is contraindication. ACE inhibitor decrease mortality and decrease morbidity and mortality in patients with MI, systolic dysfunction, and decrease progression of diabetic nephropathy, as we mentioned. The main side effects of ACE inhibitor are dry cough, hypotension, hyperkalemia, not hyper, I don't know how is that. Sorry, hyperkalemia, especially in patients with renal impairment. And acute kidney injury, especially in patients with volume depleted. Angiotensin receptor antagonist. Block angiotensin 2 on the vascular smooth muscle, thus causing vasodilations, decrease systemic vascular resistance, and decrease secretion of vasopressin and aldosterone, and therefore decrease blood pressure and stroke. ARBs are considered an alternative first-line treatment for hypertension in elderly population when diuretic is contraindication and the patient cannot tolerate ACE inhibitors. In elderly hypertensive patients with diabetes or heart failure, ARBs are considered an ACE inhibitor. Consider the first-line treatment. ARB are considered the first-line treatment for an alternative to ACE inhibitor in patients who develop cough or cannot tolerate ACE inhibitor. Calcium channel blocker can be used as first-line treatment in managing hypertension in elderly if diuretics are contraindication or if the patient has angina or heart arrhythmia or conduction problem. Most common adverse effects for calcium channel blocker are symptoms related to the vasodilations, such as ankle edema, headache, postural hypotension. Short-acting calcium channel blockers are not preferable in treatment of hypertension in elderly. Beta blocker are not an optional as first-line treatment in elderly patients with hypertension. Beta blocker should show more prevention in patients from myocardial infarction, but were also associated with higher incidence of persistent depressive mood, which is rising problem among elder population. Beta blocker can be added in combination therapy and have a proven role in treatment in elderly patients with hypertension complicated by coronary artery disease, heart failure, and arrhythmia. Alpha receptor antagonist. Alpha blocker are not considered first-line antihypertensive therapy in elderly, are used primarily for urinary symptoms related to benign prostate hypertrophy. They are include orthostatic they can induce orthostatic hypotension and increase the risk for fall and injuries. Minoxidil can cause fluid retention, reflux tachycardia, and atrial arrhythmia. Centrally acting alpha blockers such as clonidine can cause sedation, bradycardia, rebound hypertension if stopped abruptly. Refractory hypertension. Refractory hypertension is uncontrolled blood pressure despite using of 3 antihypertensive agents of different classes and in maximum doses. Factors contribute to refractory hypertension include simply could be incorrect technique in measuring the blood pressure, or poor patient's adherence to medications, or inadequate doses, or inappropriate combination, excessive alcohol consumption, patient have sleep apnea, or could be the patient has secondary hypertension. Refractory hypertension, if the patient have refractory hypertension, should be referred to nephrology or hypertension specialist. Okay, hypertensive emergency. Definition of hypertensive emergency is elevated blood pressure more than 180/120 and associated with end organ damage, such as hypertensive encephalopathy, pulmonary edema, aortic dissection, or unstable angina. Management supposed to be in the hospital with continuous blood pressure monitoring, parenteral administration of antihypertensive medications such as ciltapine, nicardipine, esmolol, and fendelobam. Blood pressure should be reduced gradually over the first 6 hours to 160/100. Do not initially target the blood pressure to be normalized, because abrupt reduction in blood pressure had a major risk of organ perfusion. Hypertensive urgency. Hypertensive urgency is elevated blood pressure without end organ damage. In this type of patient, we should lower the blood pressure over a period of 1 to 2 days with oral antihypertensive medication such as angiotensin converting enzyme inhibitor or angiotensin 2 receptor blocker, and glucose monitoring should be obtained for these patients. The goal of treatment of hypertensive urgency is to prevent end organ damage. Principle of this slide will show principle of hypertensive treatment in elderly patients. First, we will start with lifestyle modification. If that will not control the blood pressure to the target measures, then we will start drug therapy. If there is no without compelling indications, there is no risk factor. For stage 1 hypertension, For stage 1 hypertension, systolic blood pressure more than 140, 159 millimeter mercury, and diastolic 90 to 99, we consider use ACE inhibitor, ARB, calcium channel blocker, diuretics, or combination. Stage 2 hypertension, systolic blood pressure more than 160 over 100. Majority require 2 or more drugs to reach the goal of optimal blood pressure. If the blood pressure more than 20, if the blood pressure more than 20 millimeter mercury above the target, the initiation of combination medication is considered. The combination of amlodipine with RAS, renin aldosterone system blocker, may be preferred to diuretic combination through earlier applicable. So if there is a compelling indications, there is a risk factor such as heart failure, post myocardial infarction, coronary artery disease, angina pectoris, or aortic aneurysm and diabetes, or CKD, or recurrent stroke, or early dementia. So in this population, we use the initial therapy or the optimum therapy for them. For heart failure, we use thiazide, beta blocker, ACE inhibitor, ARB, calcium channel blocker, or aldosterone antagonist such as spironolactone. Patients has a history of MI, we use beta blocker, ACE inhibitor, aldosterone antagonist, and or ARBs. Patient with history of coronary artery disease, we use thiazide, diuretic, beta blocker, ACE inhibitor, or calcium channel blocker. Angina pectoris, we use beta blocker, calcium channel blocker. Patient with aortopathy or aortic aneurysm, beta blocker, ARBs, ACE inhibitors, thiazide, or calcium channel blocker. Diabetic patients, ACE inhibitor, ARB, calcium channel blocker, thiazide, or beta blocker. Chronic kidney disease, ACE inhibitor, ARB. Recurrent stroke prevention, we can use thiazide, ACE inhibitor, ARB, or calcium channel blocker. Patient with dementia, there is no blood pressure control should be blood pressure control is indicated with combination therapy. So the patients with all this medication are not reach the target goal for blood pressure with optimized dose, with adding additional drugs until the goal of blood pressure is achieved. Okay. So if all that is not with combination medication and with maximum dose, and the patient was not, we mentioned that consider refractory hypertension. We supposed to refer that patient to a specialist, hypertension specialist, or to nephrology department. Okay. Hypertension in long-term care setting. So hypertension accounts for 33% to 66% of resident patients in long-term care facilities. There is no studies or no well-designed trial or studies that prove that antihypertensive treatment in the long-term care setting. Risk and benefit ratio for treatment is unclear for patients older than 80 years old or patients with multiple comorbidity or polypharmacy taking multiple drugs. Antihypertensive medication are risk factor because it can cause hypotension. So it is risk factor for fall, syncope, and subsequent injury from that. So we're supposed to assess patients for postural hypotension and postprandial hypotension. So follow-up visit for any patient with hypertension. During the follow-up visit, we assess the adherence of medication. We have to inquire about how the patient adhere to medication. Is he missing any doses, and so on. And monitor the adverse effect of medication. So if the patient develops any adverse effect, such as cough in ACE inhibitor, we have to change the medication to ARB. We have to advise the patients to use home blood pressure monitoring. Okay. During the follow-up visit, also we adjust the dose according to blood pressure control. We encourage the patient to continue lifestyle modification. Encourage them for regular exercise, avoid stress, and also we evaluate for refractory hypertension. In summary, blood pressure control reduce mortality, morbidity, and cardiovascular effect in elderly population. Lifestyle modification should be continued even with drug therapy. Thiazide diuretic are considered the first line therapy because it is tolerated and it's not expensive and with not that much side effect. Medication should be started at low dose and titrated slowly according to blood pressure control, blood pressure level. Patients should be monitored for drug side effects such as hypotension, which can contribute to syncope, falls, and injury. Regular follow-up is mandatory to ensure blood pressure control. There is some questions that I take it from your website, so we can go through it now. So this patient, the seventh report of the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of high blood pressure recommend which of the following for initial treatment of hypertension in adult population? Is it ACE inhibitor, thiazide diuretic, calcium channel blocker, beta blocker, or ARBs? Hello, are you awake? Hello?
Yes, they're responding on the chat, Dr. Shaza. So far, it looks like everybody is choosing option B.
Yes, thiazide diuretic is the correct answer. Thiazide diuretic is considered the first line treatment of hypertension in elderly. So question 2. 70 years old man comes to the office to establish care. He is generally healthy and has always had normal blood pressure. His family history includes diabetes, hypertension, her father died of stroke, and his mother had cancer. He eats low salt diet, low fat diet. On examination, blood pressure 150/90 without postural change. Cardiovascular examination normal, and there is no evidence of hypertensive retinopathy or peripheral vascular disease. Laboratory studies include creatinine level 0.8 milligram per deciliter and ECG are normal. At repeat check 1 month later, blood pressure is 154/92 without postural change. The patient report that the reading taken with Brent's blood pressure cuff was 134/80. Which of the following is the most appropriate next step in management of these patients? Increase blood pressure. To do a repeat blood pressure measurement in 1 month, or obtain 24 ambulatory blood pressure monitoring, or refer to dietitian or dietary counseling, or recommend a regular exercise regimen, or to start thiazide diuretics. So,
So again, it looks like everybody is going with option B.
yes, option B is the right answer, is 24-hour ambulatory blood pressure monitoring to be sure that and to confirm if he had hypertension or is it just white coat hypertension. So 80 years old man comes to the office for routine evaluation. Has history of osteoarthritis, major depression, and well-controlled hypertension. Medication include hydrochlorothiazide in the dose of 12.5 milligram per deciliter, escitalopram 20 milligram per day, ibuprofen for 400 milligram every 8 hours, and valsartan 80 milligram per day. The patient's blood pressure reading is at home 160/80. So it's still not controlled. Which of the following is the next step in the management of this patient's hypertension? To increase thiazide diuretic more than 12.5 milligram, or to stop escitalopram, or stop ibuprofen, or increase valsartan, or add amlodipine.
So everyone looks like they're choosing option C, Dr. Shaza?
Yes, so stop ibuprofen because there is a link that non-steroidal anti-inflammatory medication had a role in increased blood pressure. So thank you for your attention. I'm happy to take any questions.
Thank you so much, Dr. Shaza. This is a big topic and it's an important one. So you did an excellent job. Thank you so much for reviewing all this and going over the cases. Any questions?
You're welcome, Dr. Nader. I'm sorry I take long time, it's supposed to be like 30 minutes, but
That's okay, but it's an important topic, is why we should focus on it. and you're gonna see most of your patients as they get older. You're gonna see a lot of patients with hypertension, and to understand the management, it's very important. Education is number one. Making sure the patients are taking their medications on time, and then adjusting if you need the dose or adding more medications. So the problem is always how to control it without going into another problem, which is polypharmacy. Like you're gonna give too many medications to the same patient. Thank you.
You're welcome. Thank you. My pleasure.
Okay, thank you, Dr. Shaza, for the great presentation. So inshallah, next we have Dr. Sally and Dr. Ayat. They'll be presenting the presentation on systemic review. Please, whenever you guys are ready.
You're welcome, guys.
Hello, everyone. Hello, Dr. Nader. How are you?
Excellent. Thank you so much. When you are ready, you can share the screen.
1 second.
Dr. Shaza, just please stop sharing so that they can share.
You can see my screen?
Yes.
Yes.
Okay, and now we will talk about systematic review. I think everyone has idea about or maybe not, but I think you heard about systematic review before. So today we'll get to know a little bit about systematic review and how can we conduct a review. First, systematic review is one of the secondary research, and some call it the desk research. I will go first for its importance. It gives you a summary about the previous research that they done about any specific topic you're interested in. So it will prevent you from duplication. If you want to do a research for a topic, you go for reviews and see if in any previous research address this topic or not. And also it's important for any physician to be updated to his field, and for students also. First, I will go to know the difference between the research, primary research and secondary research. First, the primary research, I do research. I will be the first contact with the research subject. It will be directly with the subject, and also it requires the ethical approval. I should have like consent and the IRB stuff. But for reviews, it's already I have the research and the data already, and it doesn't require ethical approval. For primary research, I do it through surveys, interviews, focus groups, observation techniques. But for the reviews, I do it through internet, libraries, archives. For primary research, I have the ownership of my data 100%. But for reviews, anyone can access my data. For primary research, it's expensive, it costs money. Sometimes we need the sponsor to help us to do our research, and it's time consuming. It can take more than years to do it. But for review, we can do it without need money, big money, and it can do it through weeks to months. For primary research, we gather data or we do the research because we have a problem, we need to solve it. So we do it in the process to solve this problem. But for review, it's not a must to have a problem that we need to solve it, but maybe like we need to focus or have the light on a field or on a specific question. For primary research, we need trained researchers that they took courses about ethics, about conducting trials. But for reviews, we don't need trained researcher. For primary research, examples that as clinical trials, as observational studies like retrospective or prospective. But for secondary research, as a systematic review, meta-analysis, and for the types of secondary research, we have common types we have is literature review, systematic review, and meta-analysis, where I will have a little difference between them. First, literature review, it summarizes a topic in as a story, and it's abroad in the idea, like I can discuss the cancer treatment, but for systematic review, I have a specific question, like if I have question, is vitamin C or chemotherapy is better for cancer treatment for patient over the age of 50? So it's a specific question for a specific treatment for a specific patients. For literature review, I can use sources that are biased. I look at everything, any type of studies. It doesn't follow strict systematic method. And no quality checks I need for the studies that is included. But for systematic review, it has a specific guideline as Prisma. Prisma is a checklist for reporting. Like it as a guide, tell me that I'm doing the right way. It's supposed to be the review. I'm taking the right studies. It like assess the quality of the studies that I have. It can include a meta-analysis, but it is not a must. For meta-analysis, it is look at the studies. It may be as a systematic review, but it like studies or analyze the studies in a statistically significant way. For example, if you want to examine a specific headache intervention without running a clinical trial, you can look at other studies that discuss this topic and analyze, combine them and analyze them statistically and see if it's significant or not. So if you see, you have the literature review, it's a broad term, and systematic review is more specific, and it can include the meta-analysis or not. And now we'll go to the steps of conducting systematic review. First, you need to have an idea or a question, and it's not easy. Maybe this is the most difficult step for me. To have the idea or to have the answer, the most important thing to know, not to be too broad. Like you have, like as the cancer treatment is, it is a broad question. You can, if you go and search for it, you will have huge or massive numbers of the research that answers your question. So it will be impossible to have an idea. But if it's too narrow, you can have specific question, but no one addresses this question before, or you won't have like a decent number of studies that you can build a review on it. So now you can look at the available evidence and make sure you have a specific and clear question to make you move to the next step. And the next step is to search for the studies after you have an idea. You can search it through multiple ways, like through papers, I mean newspapers, if you have published papers, articles, books, database, and we have multiple databases like Google Scholar, Cochrane, PubMed, and many other. I think you may be familiar with some of them. And the third is the screening for the studies, and I will give mic to Ayat to continue. Ayat, are you here?
Yes, okay.
Yeah.
Hi, everyone. Can you unshare your screen so I can?
Yeah, yes, I will. 1 second. Okay.
Oh, okay. Okay. You guys can see my screen now?
Yes, Ayat.
Okay. Sorry. The third step is to screen the studies that you already select from the database. So, because if you go through all this database, you will find like ton of studies for the same subject. So you have to do some exclusion criteria or filters. What studies are eligible to be included and what are not. You will use these filters like year considered, language of the studies, types, humans or animals are used, the age and the sex. I was planning to show you like an example. If you go through PubMed and you are deciding to screen for like, say, diabetes or vitamin D, you will find like 5,000 results of the studies for the same topic that you select. And you cannot go through all these 5,000 studies. So you have to do some filters by the, like I will select 1 year, the studies that are within 5 years. That will narrow my selections to like 2,000 something. And you can select the studies that are done, like we are doing geriatrics, so we can do like selection by age or to exclude the pediatrics and the people are less than, like I would say more than 65. Now I have like less studies, and you can select by like the type of the study, and we will like filter your studies to get less number of studies, so you can go through all of them and select which you want.
Excuse me, Dr. Ayat.
Yes.
I think you are sharing the other screen. We are just on the screen where it says first screen the study. So I think you are, can you unshare and then share the screen
Okay.
that we want to share?
Mm-hmm. Okay. You can see the PubMed.
Yes.
Okay. So I'm giving example of how to screen my studies by like, if I go through PubMed to choose one type of study, like if I decide to take diabetes or vitamin D, there is like 24,000, more than 24,000 studies or results for diabetes, and I cannot go through all these studies, so I have to do some filters for them. Those are the filters that you can use. Like you can filter by the years, like you can use the only new studies like 5 years until now, that will give you less. Because we are doing like geriatric research, we can select like age more than 65. And there is a lot of additional filters like sex. You can select female or males, but this will give you like some bias because you can't do studies for only one sex. But sometimes you can do it. You can select which journal you want to select, the age we set, and the type of studies. And the language, like if you can't do any language, you can select only English one. So this will narrow the selections and will narrow the amount, the number of studies that you get by the end. Okay, I will go back to my presentation. After the selection, you make a data sheet for the selected studies with subheadings. Example, like the author's names, title of the study, year of publications, DOI of the study. And now you have the data sheet for your studies. The next step is to quality check the studies that you select. For systematic review, we usually don't do the quality check for every like article that we select, but if you want to do meta-analysis after the systematic review, you have to do quality check for each paper that you select. the quality check depends on the type of the papers or articles that you have. So to assess the quality of the studies and the risk of bias in the studies, and the risk of bias using, you can use two scales. NOS scale is Newcastle Ottawa scale. This tool used to select the quality of non-randomized studies. It's in the left side, the bottom one. This is a Newcastle Ottawa scales. You list your studies by the authors' names, and there is like selections. It's already there. You give them scales, or you give them scores, and you get this total scale. And you will select the studies based on the total scales. Like you will decide to take the studies that only get 6 points and up for your review. There's other scale called JDAT scale. It's for clinical trial scales. It's in the left, the top one. You will list the name of the authors, and there is questions already there for the scales. You answer the question, and it will give them like points. And this is the total score you get for the studies. You decide the same with like which will be the cutoff for your articles. The next step after the quality check is to extract the data from the selected articles. To extract the data, there are 3 steps you have to go through. First, you will go through the title and abstracts of each study to decide whether or not the study is eligible for inclusion. Like you will only read the title of the study and the abstract, and you will find out like if this study is related to topic that I select or not. The second, take another look for the selected studies from the first read, like take a closer look by screening the full text to determine eligibility that was unclear at the first screen. Like after the second read, after you read the full text, you can still decide there is some studies is not related, so you can exclude them. The last step is to extract the data from the selected study that help you to answer your question using extract tools as like top 10 data. It's tools that help you like to organize your articles and get what you need easily from them. The fifth step is to analysis and present results. Like now you have data, but you want to like do some analysis and present them to the people in accessible format. So it is the process of putting up data in attractive and useful manner such that can be easily interpreted. You can make them like text presentation or data table or diagrammatic presentation. Next, you compare and combine the data without or with meta-analysis. The difference is like you can do meta-analysis from systematic review if the data that you have is quantitative, because meta-analysis will deal with numbers, so you have to get quantitative data to do meta-analysis. Or if you have qualitative data, you cannot do meta-analysis. So like the decision to do meta-analysis depends on the quality and heterogeneity of included study, not your ability to do it or not. Like you can't do meta-analysis for all systematic review. The sixth, report your findings in 3 steps. Like to report your finding, you present the result in narrative summary explaining the results and comparing between the papers and mention the relationship between them. Then mention the strengths and the limitation of your review and what ID added to the topic. 3, make clear conclusion and give indication for future research needed and recommendation if possible. Like you have a question from the beginning and you did a research. So you have like to answer your question by the end. And you have to make another question by the end to and I answered this question, but I made another question for the following researchers. They can because the research have to go on. So there is one thing that the Prisma checklist is used for the systematic review, but because it is a different topic and someone will present it after, so I made it like this for my college. Now this you are ready set to submit your research. Thank you. If there is any other question.
Does anyone have any questions for Dr. Ayat or Dr. Sally? If not, thank you so much, Drs. Ayat and Sally, for a very informative presentation. We appreciate it a lot. Inshallah, next we have Dr. Samah and Dr. Lina. They prepared the presentation, and inshallah it will be presented by Dr. Samah. She's going to present Prisma statements, and then inshallah followed by Dr. Nagla with Prisma explanation and elaboration.
Hello, everyone, and good afternoon.
Hello, Dr. Samah. Thank you very much.
You're welcome. So today, can you see my screen, please?
Yes.
Okay.
Yes.
All right. So I will present the Prisma statement. Basically, we have the history and development of Prisma. Sorry, I can close this. So systematic reviews and meta-analysis have become increasingly important in the healthcare. The clinician reads them to keep up to date with their field, and they are often used as a starting point for developing clinical practice guidelines. And granting agencies may require a systematic review to ensure there is justification for further research, and some healthcare journals are moving in this direction. So as with all research, the value of systematic review depends on what was done, what was found, and the clarity of reporting. As with other publications, the reporting quality of systematic review vary, limiting readers' ability to assess the strengths and weakness of those reviews. So there are several early studies evaluated the quality of review report. So in 1987, Melro examined 50 review articles published in 4 leading medical journals in 1985 and 1986. After his study, he found that none met all 8 explicit scientific criteria, such as the quality assessment of included studies. So in 1987, Sachs and his colleagues evaluated the adequacy of reporting of 83 meta-analyses and 23 characteristics in 6 domains. After they did the reporting, they found that the reporting was generally poor. Between 1 and 14 characteristics were adequately reported. So the mean of their study was 7.7, with a standard deviation of 2.7. So in 1996, they updated this study, and after that, they found there is a little improvement. In 1999, to address the suboptimal reporting of meta-analysis, an international group developed a guidance called QUORM statement, which is the quality of reporting of meta-analysis. So this one focuses on the reporting of meta-analysis of randomized controlled trials. In 2009, the guideline was updated to address several conceptual and practical advances in science of systematic review and was renamed Prisma. So from there, Prisma came, and the name Prisma means preferred reporting items of systematic review and meta-analysis. So they join both the systematic reviews and the meta-analysis, which is discussed before by Dr. Sally. And they tried to conduct another one, which we call it now Prisma. So the Prisma statement was published in multiple journals and accompanied by explanation and elaboration papers. And then to ensure its currency and relevance, in 2017, an international group set out to update the Prisma 2009 statement by incorporating advances in systematic review methodology and terminology occurring in the last decade. Then the Prisma 2020 statement was posted as a preprint of meta-RVX in September 2020 and published in March 2021. So this is the first time that it published in a complete way in March 2021. A detailed description of the method used to update the Prisma statement. So the Prisma statement, which is our topic, was developed by a group of 29 review authors, methodologists, clinicians, medical editors, and consumers. So they attended a 3-day meeting in 2005 and participated in extensive post-meeting electronic correspondence. A consensus process that was informed by evidence whenever possible was used to develop a 27-item checklist and 4-phase flow diagram. So when we talk about Prisma, usually we talk about the checklist, and the flow diagrams. We will give examples by the end. So the flow diagram item deemed essential for transparent reporting of a systematic review were included in the checklist. The flow diagram originally proposed by the QUORM was also modified to show numbers of identified records, excluded articles, and included studies. So after 11 revisions, the group approved the checklist, flow diagram, and explanatory paper. So this is an example of the flow diagram. They start phase by identification. So for example, no record identified through database searching, and no additional records identified through other sources. We will go to the other step, next step, which is screening. So in screening, no of records after duplicates removed. No of record screened. We go for no of record. So no of record excluded. Then the eligibility. No of full text article assessed for eligibility, and number of full text article excluded with reasons. Then included number of studies included in qualitative synthesis. And finally, number of studies included in quantitative synthesis, which is meta-analysis. So we start with identification, screening, eligibility, and finally, what included. And next we will go for the checklist, which will be presented by Dr. Ayat.
Yes, thank you very much, Dr. Samah. So now we have Dr. Nagla. She's going to go over the Prisma 22 checklist. Thank you very much.
Yeah, hello, everyone. Let me share my screen. Or just keep your screen, Dr. Samah.
Okay.
Whatever is easier. Okay.
My screen. Yeah. If you need, you can share yours. It's okay.
Yeah, it's okay. You can keep it.
Okay.
So now I'm gonna present the Prisma 22 checklist, which consists of 27 item checklist. As you see here, we have 3 columns from left to right. The first column is section and topic, and then item number, and then checklist. And at the end, there is location where item is reported. And in this, most probably it will be the page number. From left, first the title. In the title, we'll identify the report as a systemic review. Then the abstract. In the abstract, you can see the Prisma 2020 for abstracts checklist. Most probably will be the summary of the outcome. Then I'm going to go to the introduction. In the introduction, we have to rationale and objective. The rationale, this one describes the rationale for the review in the context of existing knowledge, and the objective provide an explicit statement of objective or question the review addresses. Then the methods. In the methods from 5 to 15, first the eligibility criteria. In the eligibility criteria, we'll specify the inclusion and exclusion criteria for the review and how studies were grouped for the censuses. Then information sources, specify all database, registers, website, organizations, reference list, and other sources searches or consulted to identify studies, specify the date when each source was last searched or consulted. The search study, this one presents the full search strategies for all the database, registers, and websites, including any filters and any limits used. Then the selection process. In the selection, we'll specify methods used to decide whether a study met the inclusion criteria of the review, including how many reviewers screened each record and each report retrieved, whether they worked independent, and if applicable, details of automation tools used in the process. Then data collection process. In data collection process, we'll specify the methods used to collect data from reports, including how many reviewers collect data from each report, whether they worked independently in a process for obtaining or confirming the data from study investigations, and if applicable, details of automation tools used in the process. Then the data items, it will be 10A and 10B. The first, list and define all outcomes for which data were sought, specify whether all results that were compatible with each outcome domain in each study were sought. For example, all measures, time point, analysis, and if not, the methods used to decide which result to collect. And then list and define all other variables for which data were sought. For example, participant and intervention characteristic, funding sources, describe any assumption made about any missing or unclear information. Then we'll go to study risk of bias assessment. We'll specify the method used to assess risk of bias in the included studies, including details of the tools used, how many reviewers assist each study, and whether they worked independent, and if applicable, details of automation tools used in the process. Then the effect measures. In the effect measures, specify for each outcome the effect measures, for example, risk ratio, mean difference used in the censuses or presentation of results. Then the censuses methods. In the census methods, first describe the process used to decide which studies were eligible for each censuses. For example, tabulating the study intervention characteristic and comparing against the planned groups for each censuses. And then describe any methods required to prepare the data for presentation or census, such as handling of any missing summary statistics or data conversion. Then describe any methods used to tabulate, or if I need visually display results of individual study and censuses. Then 13D, describe any methods used to synthesize results and provide rationale for the choice. If meta-analysis was performed, describe the models, methods to identify the presence and extent of statistical heterogeneity, and software packages used. Then 13E, describe any methods used to explore possible causes of heterogeneity among study results, for example, subgroup analysis and the meta-regression. The last thing in synthesis method, describe any sensitivity analysis conducted to assess robustness of the synthesized results. Item number 14, reporting bias assessment. In reporting bias assessment, describe any methods used to assess risk of bias due to any missing result in a synthesis arising from any reporting bias. Item 15, certainty assessment, in which you describe any methods used to assess certainty or confidence in the body of evidence for an outcome. Then the result. In the result, I have from 16 to 22 checklist items. Study selection. First, describe the result of the search and selection process from number of records identified in the search to the number of studies included in the review, ideally using a flow diagram. And then cite studies that might appear to meet the inclusion criteria, but which were excluded, and explain why they were excluded. Then item 17, study characteristics, cite each included study and present its characteristic. Risk of bias of studies, present assessment of risk bias for each included studies. Item number 19, result of individual studies for all outcomes, present for each study. Summary checklist for each group where appropriate, and number B, an effect estimate and its preciseness, for example, confidence, credible interval, ideally using structured tables or plots. Then we'll go to the result of synthesis. Result of synthesis, 20A, for each synthesis, briefly summarize the characteristic and risk of bias among contributing studies. 20B, present result of all statistical synthesis conducted. If meta-analysis was done, present for each the summary estimate and its precision, for example, confidence and also credible interval. And the measures of statistical heterogeneity, if comparing groups, describe the direction of the effect. 20C, present the result of all investigations of possible causes of heterogeneity among study results. 20D, the last one in the results of synthesis, present the result of all sensitivity analysis conducted to assess the robustness of the synthesis studies, results. Then the reporting bias, present assessment of risk of bias due to missing results arising from reporting bias for each synthesis assessed. Then the certainty of evidence, present assessment of certainty or confidence in the body of evidence for each outcome assessed. Then the discussion. In the discussion, first provide general interpretation of the result in the context of other evidence, and then discuss any limitation of evidence included in the review. Discuss any limitation of the review process used, and the last thing, discuss implication of the result for practice, policy, and future research. Other information. First, registration and protocol. It will be three topics. First, provide registration information for the review, includes the register name, register number, or state that the review was not registered, and then indicate where the review protocol can be accessed or state that a protocol was not prepared. Then describe and explain any amendment to information provided at registration or in the protocol. Support this checklist item number 25, describe source of financial or non-financial support for the review and the role of the funders or sponsors in the review. Completing interest, this checklist number 26, describe any competing interest of review authors. The last one will be availability of data, code, and other materials. Report which of the following are publicly available and where they can be found: template data collection format, data extracted from included studies, data used for or analysis code, and any other material used in the review. And this is the last one in the Prisma 22 checklist.
Thank you so much, Dr. Samah and Dr. Nagla. If anyone has any questions, please feel free to ask.
Thank you so much, all the presenters, and this is also great. And the important part of this discussion is that when you want to write, there are certain ways to write, like an abstract or write a manuscript. So if you follow these steps, it will make life easy for you. It will make things easy to achieve. Thank you.
Hello, Dr. Nadir, you're muted.
Yeah, I was just about to say that. You're muted, doctor.
All right. Thank you so much for all the presenters, and this is great. Thank you, everyone. I just want to mention that presenters, Sari, Ayat, Samah, and Nagla. Thank you for the great presentation. There are a couple of things that we want to know when we are looking at this, like the Prisma steps. It's very helpful tool when you are trying to use a topic you want to write about it. So this way will make your steps organized and follow the guidelines in this area, and it will make your systematic review more informative. Thank you, everyone. Any questions? Any comments?
Dr. Nadir, I want to just add that I added a link for expanded in detail 2020 Prisma checklist for everyone to review.
Excellent. That's also great. Thank you. Yeah.
Dr. Nader, if you'd like, I can also just upload all the presentations from today onto the app for everyone to be able to access them, okay?
Perfect, that's excellent. Thank you so much. So we can move on to the next agenda. Any questions, ideas regarding the research topic or projects, any updates?
Hello.
Hello, yes.
Good evening, everyone. Thank you for the presentations. Regarding the updates for the COVID pancreatic disease comparison between the geriatric and pediatrics. Right now, we're just editing, and hopefully in the next couple of days, we'll all agree on the final edits, and we'll provide it to Dr. Nader, and we can discuss furthermore. But thank you.
Excellent. Thank you so much. So last year, the group of the fellows, they submitted, I think, 3 or maybe more abstracts to the AMA challenge. And I think the deadline is coming soon, less than a month from now. It will be July 12th. So if you have an idea of doing an abstract that we can submit to the AMA, maybe we can work on that and get it ready to be submitted. You can look at previous work, and I'm going to share the link for that with you guys. But basically, they have at least 2 or 3 abstracts presented there. So you can look at the AMA previously, which products went and how we can do the same if you want to. Lina, go ahead.
Hi, how are you? Thank you, everyone. It was very, very informative presentation. And we started a topic of disparities, racial disparities in nursing home residents. We found, we were collecting data, and we found around 25 articles, and there is a chance for more. I just wanted to ask whether is it enough, 25 is enough to do a literature review, or do we need more? And after this, after we confirm, we're gonna go ahead and start the what it's called, the editing process, and like reading and extracting informations.
Thanks for sharing. Yeah, the number 25 is okay, and you can work on that. Thank you.
We also were, I'm in a group where we're working on the association between chronic stress and Alzheimer's disease. Right now, we divided the topics between us, and we are in the process of evaluating the data and also extracting the information, so we can hopefully next week start with the writing.
Excellent. It's also a great step. Thanks for the effort. Thanks for sharing. So I shared with you the link for the previous publication, the work done by the fellows in the past year also. Any other updates? Go ahead, Dr.
Yes, hi, doctor. So we're thinking about doing a literature review on the atypical presentations of COVID-19 in older adults. We found like falls, reduced mobility, and delirium. But then we found a similar article that was done particularly covering falls. And we were thinking, should we like cover all of them, or maybe choose one atypical presentation and then cover it?
I think it might be a good idea to focus on one and cover it, and take it from there. Excellent. Brian, go ahead.
Yes, Dr. Nader. So I was thinking of doing a research project on the effects of anesthesiology on post-cognitive dysfunction in elderly patients. I just kind of wanted to get your feedback. I was thinking to do a literature review with that, but I just kind of wanted to present the topic and see what you think, just get any feedback. If it's, I did do some research, like I searched on PubMed and I found a lot of articles. I just have to go more in depth to them. So there is information out there regarding it, but yeah, I just wanted to connect with you about that. What do you think?
Definitely, it's a good area to investigate more, and I think it's a great question. So if you already start find something, then yeah, I would go ahead. You can start the project.
Come on.
In the past, I think here in Michigan, one of the surgeons was actually seeking to start a project about the delirium and post and pre-evaluation of all the other, like after surgery. But I don't know if they started that project, but it's a good idea. Anesthesia.
I'm so sorry, doctor, but your voice is very low. I'm so sorry. I didn't hear
No, that's
the last
fine.
part.
That's fine. Oh, yeah. Thanks for letting me know. And,
I apologize.
I used a different mic. Is that better now? Can you hear me better?
Yes.
Okay.
Yes,
Yeah.
I can hear you.
So, yeah. So basically, I agree with you, Ryan. It's a good area to explore or to, yes.
Yeah, I haven't, I don't have a group yet, so I'll just, I'll present it, and then whoever wants to work with me on that can go ahead. Thank you so much, Dr. Nader. I appreciate it.
No worries. Thank you. Dr. Ayat, go ahead, followed by Dr. Manha.
Just I had a question for everyone. Like, I want to know if there is any group that are doing research now. I want to join them, or like if there is any opening, let me know.
So maybe Dr. Ayat and Dr. Ryan can get together and see if we can form a team for the idea we just discussed. Thank you. How about you, Dr. Manha?
Yes. Good evening, everyone, and thank you for the very informative presentations. Regarding the updates, so me and the dentist group, we would like to start a project about the correlation of Alzheimer medications and xerostomia in geriatric patients. So we need your feedback about this topic, and if that's if we get the your feedback and that's okay to start, so I will email you the topic name and the name of the participants, like of the whole group. So what do you think?
I think it's also a great idea. If it's not done, maybe we can explore that and do the study. That's an excellent idea.
Yeah, we did. We didn't find the same, the same, like the exact same research, but there is a related information, like related projects, but not the same thing. So, yeah.
Sounds good. So shoot me an email and we can start from there.
Okay, thank you so much.
Thanks. Any other updates or any other ideas?
Oh, Dr. Nader, this is me here.
Right. Yes, go ahead.
Sorry. So earlier you mentioned about the deadlines for those abstracts for the AMA conference. Where can we see them on the TGRF app? Are they on the app somewhere or?
No. I just talked to Amy and
okay.
She mentioned the July 12th. So
okay.
I just want to share with you guys.
Sure.
Yeah.
Thank you.
Yeah. Any other questions or any other comments, any other suggestions, ideas for research? Go ahead. I don't see the name, but go ahead. You raise your phone.
Hello, Dr. Nader. Yes, I'm Maya
Go
Itwani.
ahead.
Yes.
Yes,
How are you, Doc? Good.
Very good. Thanks.
Good. Hello,
Go ahead,
everyone.
Hassan.
Yes, Dr. Nadir, just want to ask, I also want to participate in any research article. If there's an opportunity, I'm ready for it, please.
Sounds good.
Thank you.
So, as you as well, you can get in touch with Dr. Ryan and you can form a group there.
Thank you so much. Yes, I will connect with her. Thank you.
Yes. Thank you. And again, so we have the organization as teams. So each team has their own leader, and this leadership can be like for a couple of weeks, and then we can switch off it, rotate the role so that every one of you can at least have an opportunity to lead a team and see how they can gain skills as far as the leadership skills. And personally, you can identify areas for improvement, let's say coordination or organizational skills. This will come as you apply the concept with your teams. So this is one part of the fellowship. The other part is what we were just discussing, the teams related to the project. So each project, they have their own team, and then the project leader for that team will organize and will identify the task, what needs to be done, and then divide it between the team members in that research team. And then when finished, everyone will be listed as authors. So my suggestion is for every one of you is to identify areas to work on at least one project, research project, and join the research team in that area. If, for example, some of the teams, we want to go to the maximum number, we said maybe 10, give or take. Just because when we apply to these conferences, some of them might have limitation when we submit as abstract. We don't want to give them 20 authors. Although if we want to write an abstract, a manuscript, for instance, and the topic is a very big and impactful topic, there is no limitation as far as how many authors will be there. So if you have a good topic you want to work on and we want to publish it as a manuscript, an article in a journal, there is no limitation for that research project or manuscript to write, especially if it's a very important topic. So just think about that when we are communicating with the team leaders or with the project leaders. The role for the team leader is to make sure every one of the team members is at least working on some area for the research. If they need help, they can get back to me and we can start talking about different options. If I'm making myself clear, otherwise just shoot me an email or talk to your team leaders. Thank you. Any other questions or comments or suggestions? Ideas? I think today we have a very excellent group of presenters and excellent topics, important ones. So, Shini, you want to add any comments or questions? Go ahead.
Yes, Dr. Nadir. Thank you. So we started on the paper like suicide in the elderly during pandemic. As you suggested, we formed a group of 8 members for now, and we all started to sort out the data. Dr. Abuzar and Dr. Hadil were working on the literatures for the paper, and Dr. Akila and and myself are working on sorting out the data, and others are joined recently. So since it's been a week, we have started working on the progress. Currently, like we'll be working on the variables like based on the age, gender, and occupation, comparing the data before the pandemic and during the pandemic. That is what we are working on right now. And we'll be searching for the journals from the link which you suggested, Doctor.
Thank you so much.
Thank you. Yeah, I'll
You're
be updating you regarding the progress.
Perfect. Excellent. So what she was mentioning or referring to, when we work on the manuscript, sometimes we need to identify areas like the journal that we want to submit to. What I suggest is using a tool called Jane. And in that tool, it will list you some of the journals that can accept or related to the topic that you are talking to. We can talk about this later in one of the coming presentations. So, thank you for sharing. And that's it. Anyone else wants to share about that bit? Any ideas? Please feel free. If not, interrupt me. Otherwise, we will talk about next meeting agenda. So for next week, the Green Team will be presenting these topics, and just these are the suggestions as well, and the names I put them there. Maybe you can change your name, or if you are not available for any reason, you can just talk to the team leader, and then they can find someone else to present. So you can look at the app and then talk to your team leader as far as next big presentation and task. I'm gonna send you emails in the coming days. So what we need to do, I think we already have some ideas about the video system we just talked about using the Prisma and other tools. So maybe it's a good idea if you have time. I know some of you might be busy with preparing for step 3 or other obligations, but if you have time, maybe you can practice using these tools and replicating some of the examples that we can share. This is one thing. The other thing, I'm gonna send you also some files similar to what we are doing now, and these are just for practice. So what I want is I want to have you to have some opportunity to practice presentation. So for instance, the topic today was about hypertension. So if I send you that file, you already have idea, you already attended today's meeting. So the file itself, we don't want you to present the whole say 40 slides. You can focus on the 10 or 15 slides and use the tool in Microsoft Word, like the coach tool, so that you can just practice yourself. If you record that, and you can share that with another fellow, and they can give you feedback. The same, they can try to record themselves, and then you can give them feedback. So you can use two tools. One of them is the Coach Online, and the other tool is to see what else actually people are looking at what you are doing, and maybe they can give you feedback. So this we used this in the past, and it helped identify areas for improvement for every one of us. There is areas always to improve on. So we will focus on these two areas in the coming couple of weeks. So again, thank you everyone for joining the meeting today. Thank you, Dr. Ryan, for moderating this meeting. Thank you for excellent presentation and excellent participation from all of you. Have a wonderful day, and we'll see you.
Thank you, everyone. Thank you, Dr. Nadir.
Thank you, Dr. Nadir.
Thank you, everyone. Thank you, Dr.
Thank you,
Nadir.
Dr. Nadir.
Thank you, everyone.
Thank you, everyone.
Thank you, everyone.
Thank you, Dr. Nadir.
Thank
Thank
you.
you, everyone.
Thank you, everyone.
Thank you so much,
Dr.
everyone.
Nadir.
Bye-bye. Thank you.
Thank you.
Bye. Thank you so much.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you. Thank you, Dr. Nader.